welcome to our webinar. We appreciate you all taking the time to join us today. I know that folks are very busy. The purpose of today's webinar is really to talk through, from a healthcare provider perspective, of course, health plans also are experiencing a lot of these challenges. How do you begin to prepare yourself, your organization, to ensure you're going to have maximum access to some of the federal dollars from the CARES Act, but also other legislation that may pass over time? And we may use hospital quite a bit, that terminology, as we talk today, but all of this applies to anyone, whether you're a hospital, ambulatory surgery center, health plan, other than, of course, some of the specific hospital language. Hospitals clearly are bearing some of the brunt on the cost side, but we also know that many other providers nationally are being hit with the brunt of this on the revenue side, as well as some of the health plans having a variation between maybe reduced utilization, but at the same time, changes in payer mix and all kinds of other challenges. So again, thank you for being here. I want to start by introducing our panel. So on our panel today, we have Dwayne Donner, and Dwayne is an executive advisor for Cope Health Solutions. He served as the president and CEO of the California Hospital Association, representing 400 hospitals and health systems in California from 1985 to 2017. For 10 years before that, he was also the CEO of the Missouri State Hospital Association. And Dwayne is just one of the most knowledgeable people on hospitals and regulatory issues related to hospitals and health systems in the country, and has been honored consistently by the ACHE and others for his service and for his expertise. Tom Doherty is a principal with Cope Health Solutions. He has more than 25 years of experience in various senior leadership roles in hospitals and health systems, has been involved in a lot of innovations, but also a lot of challenging situations. None of us have been in situations like we are now, but Tom's been through some of the various disasters and challenges over time that we've all had to face, and he's also a fellow of ACHE, very involved in education and mentoring. And Margaret Peterson. Margaret is one of our executive consultants and has just a very, very deep and long track record as a transformative CEO of hospitals, most recently at Dignity's California Hospital Medical Center, which is a trauma center in downtown Los Angeles, California. Prior to that, she was at Desert Valley Hospital and a medical group in Southern California. And she also was the 2019 chair and is the current past chair of the Hospital Association of Southern California. So great group. We're really pleased to have today. And if we can move to the next slide, please. So just a bit of housekeeping. What we're going to do today is we are taping this, and you all will receive a copy after the presentation. If you have any questions, please enter them through the Q&A feature in Zoom. If you have any problems entering there, you can also just email us, info@copehealthsolutions.com. And what we'll do is, at the end of this, we're going to do a little bit of panel Q&A for Dwayne, Margaret, and Tom to answer some of your questions. If we don't get to your question during the webinar, we are going to take all the questions, package them up in a written Q&A, and we'll get them out to you with a PDF of the presentation and a link to the recording. Next slide, please. So the agenda today, it's going to be obviously introductions we've gone through now. We're going to talk about, Dwayne will cover the CARES Act itself and really explain to us what's happening and some of his expert advisement on what this means as we go from a legislative act into reality. What should providers do now to prepare is going to be primarily Margaret and Tom walking through things from both a revenue loss and a cost perspective. We'll have a bit on additional considerations and really the call to action for what you need to be doing now, and then we'll do a brief Q&A. So that's where we are, and I am going to ask Dwayne Donner to please carry it from here. Dwayne?
Thank you, Alan. Next slide. The CARES Act, which is the Coronavirus Aid, Relief, and Economic Security Act, as you know, was passed last week. It has mandatory provisions, and it also has emergency funding provisions. In the mandatory section, there are divisions on business, unemployment, a Marshall Plan for healthcare and education, and it also provides for funding to states, local governments, and others. The payroll tax credit applies to everybody, regardless of whether they're healthcare or not. The Marshall Plan is described later, and then small business assistance is provided primarily through loans. Next slide. Now, this is the emergency funding. It has a $330 billion appropriation. In it, $100 billion to reimburse eligible healthcare providers, including hospitals and others. And it covers two things. It covers the related expenses that are attendant to COVID-19, and it also includes lost revenues. It defines the eligible providers, which we'll list later, and it will require submission of reports and documentation, which is an emphasis of this program because documentation is essential. If you receive payments from any other provider, like a private payer or the individual, those have to be deducted for the COVID-19 patients. And the OIG has 3 years after payment to present audit findings, which means that the reconciliation and the audit are going to take place sometime after we get to the ultimate resolution. The only thing I'll mention here, these are a number of the items that are included in the emergency funding, is $185 million to HRSA for covering critical access hospitals, telehealth, and tribal health. And that's extremely important because most rural hospitals do not have the resources to operate for a very long period of time without payments. These others are all delineated later. The $4 billion going into CDC is for a wide variety of things, from research and development of vaccinations to preparing for another similar kind of event through the proper stockpiling. Next slide, please. $27 billion is available through 24 for prevention and preparation, and it does include a number of things: workforce improvement, education, training, modernization, expansion of telehealth, which is throughout the entire law, and for developing vaccines and purchasing surge capacity. And we have to talk about, okay, how will we do that, since hospitals by and large have gone to just-in-time stocking over the last 25 years, and without the proper stockpiles, we end up with extreme shortages in a crisis. Nobody anticipated the crisis we have, but nevertheless, we can be better prepared in the future. Next slide. On the financing side, these provisions here affect Medicaid, and DISH being a very important part of Medicaid. This legislation eliminates the $4 billion DISH cuts in the current fiscal year, federal fiscal year 20, and it reduces the cut next year by $4 billion from $8 billion down to $4 billion. And in the implementation of the next year cuts, they don't start until December 1, 2020. No other changes were made in disproportionate share. On delaying premium, the maintenance of effort requirement, this bill delays the application of MOE that did restrict states from increasing premiums as a condition of receiving their FMAP, which is the federal matching rate increase, which was authorized by the previous bill passed by Congress earlier last month. And then on the clarification of state Medicaid option to cover the uninsured, it clarifies that non-expansion states can use the Medicaid program, their Medicaid program, to cover COVID-19 related services for uninsured adults who would have qualified for Medicaid if that state had chosen to expand. Next slide, please. This relates now to Medicare. Sequestration, as you know, we've had now for several years sequestration of 2% off of the DRG update factor, and it suspends that 2% cut from May 1 through December of this year. That's great news, but it also extends the sequestration from 2029 to 2030, so at the end. Secondly, there is a 20% add-on for COVID-19 codes, which means that whatever the payment is, there will be a 20% add-on during the emergency for COVID-19 codes. Expanded options for accelerated payments. Medicare, as you know, does allow it now, but this gives greater flexibility. Hospitals, as an example, can get a 6-month advance. They have several options for when they pay it back, but they have to pay it back within at least a year, or they will have to start paying interest. But the good news is they can get money available to meet payroll if they need that, or for something like buying PPE where they don't have the funds. And then there are flexibilities for increasing post-acute care access, probably the leading one being elimination of the 3-day requirement before you can go into a post-acute care setting. Next slide. Now, for home-based services, there are face-to-face visits between dialysis patients and physicians. That is being relaxed to some degree and will make it easier for people to get home dialysis without having the face-to-face requirement that existed before that. Enabling additional health professionals to order. That allows nurse practitioners, some physician assistants, and certified nurse specialists that are certified to give certain orders. Facilitating home and community-based support after hospital stays. This would expand certain state and community-based services guidelines to include self-directed personal assistance services and attendant services and supports. And these probably will apply to Medicaid as well as to Medicare. Next slide. Increasing access. All of these are designed to increase access, and I won't cover them individually, but there are provisions, and there will be more instructions regarding funding to allow for increasing access in these areas. And as you know, just on testing changes almost every day, and the availability of equipment also changes almost daily. So these are dynamic and will move rather rapidly. Next slide, please. This describes who's eligible. Clearly, hospitals, health systems, ambulatory care centers, FQHCs, community clinics, physician groups, rural health clinics, individual providers, and others are included. And how CMS is going to divide up the money is not yet known, but we should hear in the next several days, or maybe even few days, how they intend to make an initial appropriations and allocations. Next slide. What we know today is what we know today, and we may not be 100% accurate because it changes and may change tomorrow. AHA has recommended to CMS and HHS that they make an immediate payment to every hospital based on $25,000 per bed and $30,000 if that hospital is located in a designated hot spot. This would use about 23 billion of the money, and it would still leave obviously over 3/4 of that amount left for other providers, and then future funding for hospitals. But some hospitals are in such dire straits for money that that request is being considered. But HHS is also considering other things. A suggestion arose from the Vice President yesterday that they may use it to pay for care for the uninsured. We would oppose that. We think that the intent of the law is for that money to go directly to providers. We don't know how some of the allocations will be made. In other words, what are the rules? If it's done like on the AHA recommendation, it wouldn't matter, but there may be other times where the first come, first serve, or the ones that have the best applications or complete applications get funding first, and maybe the funds run out and others don't get it. So it's important to be precise, document everything, and follow the rules that are laid down for getting the money. As we said, start preparing now. That application process will unfold, and be prepared with the documentation, because without a doubt, the OIG is going to audit all of this, and there will be reconciliation and could be clawbacks in the event that there is an error committed by you as the provider. Next slide, please. California. This is California specific. The only thing I'll say here is California stepped up to the plate. They appropriated $500 million to help, and it could go up to $1 billion. The governor's issued 2 executive orders and waived a tremendous number of hospital regulations to allow hospitals to deal with the COVID emergency. And just yesterday, he signed an executive order that allows for the immediate use of funds to support public health and respond to the crisis. As we all know, there are 32 federal medical stations in the country, 8 of which are in California. And those are, many of them, up and ready to go. And some of them plan to launch their operations next week. One other item, in the previous bill passed by the Congress, $100 million was allocated for specific purposes to respond to the crisis. 50 million of that was then designated by CMS to go to state hospital associations for distribution to hospitals. California shares $4 million of that, and the California Hospital Association has indicated that they will make a distribution at $47 a bed as soon as that money is available, hopefully next week. In addition to government actions, some government actions have affected private plans, and some plans have taken specific actions on their own. United, Cigna, and Centene and others have said, we're not going to charge copays or deductibles for COVID-19 patients. In California, the licensing agency, the Department of Managed Health Care, issued last month an all-plan letter requiring that health plans pay providers at the same rate, whether the service is provided in person or through telehealth. In other words, a telehealth service is the same as an in-person service, and that applies to all providers, including the Medi-Cal Medicaid program, and the plans may not subject enrollees to any higher cost sharing because of that. Last slide. Next slide, please. And then at this point, Margaret Peterson is going to take over and give us a summary of what providers can do now. Margaret.
Thank you, Dwayne. Let's go to the next slide. One of the things that you're going to hear over and over again is thorough documentation, and there are 2 reasons for that. One is for beginning with the acquisition of funds, but it also helps you as an organization to be ready for a possible audit. And again, this is something that you'll hear again. In the next slides, what we're going to do is share with you some of the experiences that our clients are having across the country, but also some of your own past experiences from either having gone through Sandy or the Katrina disaster. Next slide. These are just some strategies, and some of these, make note that you probably already have in place, but we're just going to emphasize them again. Creating a task force. Now, some of you may already have a disaster plan in place and a disaster task force, but depending on the size of your organization, if you're a small organization, it may only be 1 to 3 people. If you're middle size, maybe 7 to 9 individuals. A larger organization may have 12 to 15. But what you want to keep in mind is with this group, you don't want it to be 15 to 30 people, because at that point, it gets unwieldy in terms of managing the critical data that you need to be looking at. And one of those things will be looking at your regulations, depending on the state that you're functioning in. For example, in California, ratios have been loosened at this point during the crisis. Flex waivers have been given. So what you want to do is make sure that you understand what regulations relative to your state have been either put on hold at this time or loosened in some way. Now, in terms of the task force itself, don't forget your infection prevention individual, your HR individual, somebody to represent your non-clinical departments like plan ops and housekeeping and dietary, someone to represent your other clinical areas like radiology or lab, and certainly your nursing. We always think of nursing, however, make sure that you have these other individuals because they're all going to be critical in terms of documenting where the funds are going. Now, in terms of your governance, you're going to have different governance structures. Some of you may have a board of trustees, some of you may have a management company, or it may just be one individual. Whoever it is, make sure that you communicate with them on what your processes are, what you're doing in terms of how you're planning to manage this crisis, the issues that you're having. They're there to support you, so make sure that you keep them updated. I want to jump over to briefing all the critical staff and clinicians. This is where you bring your large group together. You want to make sure that you have your middle management, your supervisors, and don't forget your informal leaders. They may not have a title, but these folks are the ones that are probably going to be spreading a lot of information. So make sure that you help them understand what the regulation changes are. And also, if you have a union, you know they're going to be involved. You may want to brief them separately. You also want to make sure that they understand the changes in the processes that you normally have that may be different during this time. One of the ways that a hospital can do this is to have either an email that goes out daily to keep people updated, bring the group together once or twice a week, or having some kind of an ongoing newsletter, just so you keep your lines of communication open. Another strategy is to assign one person. We all know that we have critical people that we depend on throughout the hospital in different areas, but during a crisis, these folks are going to be involved as really hands-on deck individuals. So you may have to bring in someone and hire someone from the outside to be that point person. And if you're a small organization, you may have someone internally. If you're larger, you may have to have more than one person that works with this individual, or you may have to move someone into this point person position or a czar position and bring someone into backfill. Now, the individuals that you bring into backfill, make sure you keep track of that because those are costs that you can, again, make sure that you try to get some funding for. Developing a strategy for the documentation process. We're going to talk a little bit more about that, so I'm going to move on from there. In terms of your expenditures, you want to make sure that the point person or point persons that you have, make sure that they are able to access all departments, that they have the data available or the mechanism. Now, during a crisis, we often will be doing manual inputting, but make sure that you have someone that's going to be turning this into digital data so that more than one or two people can access the information. You may want to make sure that the others that access it have read-only access so that there aren't a lot of people going in and manipulating the data in any way. Next slide. You want to make sure that you're also documenting in real time. Don't wait. This is a huge mistake that is often made in that you'll say, oh, no, I'll remember and I'll get to that. But we know that we often forget things. We don't always keep up with it because of all the issues that are going on. Again, you want to have people assigned to doing this that aren't in the fray of all the activity that's going on. Be thorough, capture everything. There's going to be duplication, but you can reconcile that later. When you capture data, don't forget things like food that costs that may go up, additional items that you're buying that you may not normally buy, housekeeping supplies, drugs obviously we'll be able to keep track of. But one of the things that you can do is use a binder. I love binders. People that have worked with me know that that's the best way to keep track of things, where you copy the order, the invoice that comes in with it so that you can document the number of things that you're ordering, but also the cost. the thing that you want to remember with this is that oftentimes the costs are going to be higher during the crisis. So it gives you a way to go back and compare what you've done in the past and be able to identify the additional costs that you're incurring during this time. Now with labor, there's a lot of things that you can look at. And this isn't just nursing, by the way. You want to make sure that you're inclusive of all departments and not only clinical staff, but also your other support staff that you don't always remember to document on during a crisis. Overtime is certainly something that comes out, but often hospitals or other organizations will be offering risk pay or bonus pay, hazard pay, whatever you call it. Make sure that you have that maybe in a separate bucket so that you can keep track of that. Also, you may be bringing additional staff. For example, if you normally staff a unit with 5 RNs and 3 support staff, during this time it may be 8 RNs and 6 support staff. So make sure that you don't forget those individuals. Your contract labor during this time, what we're finding from our clients across the country is that the cost of these individuals have jumped exponentially. You want to make sure that you document that, have backup to be able to identify that outside of your normal agreements that you have. So make sure that you are able to bring these individuals in. During this, for sick time, there are organizations that not always budget for sick time. They assume that they will write it off as it is used. But during this time, you're going to have a lot of calls that are sick time. And if you don't normally budget for it, you may be cash strapped. So your finance people may want to take a look at this and see how they're going to manage that. In terms of supply costs, it's going to be obviously much more than normal. Make sure that you capture the overage that you're being charged, which is the difference from your normal order, and make sure that you understand what your normal costs were so that you can identify that when you're submitting for funding. Delivery charges is something we don't always remember, but you may have overnight delivery charges, you may have just increases in those delivery charges, and you may have couriers that you use to pick up things or deliver things, and you may be sending staff to pick up things. So make sure that if you are sending staff, consider whether it's their own vehicle or the hospital or organization vehicle, and make sure that you have liability coverage for that. Next slide. You want to think beyond whatever cost accounting systems you have for capturing costs, because cost accounting systems are looking at individual physicians or groups of physicians or individual patients or groups of patients. So make sure that you look beyond that. You want to consider equipment purchases, and this is where using more than 1 or 2 heads is important when you're trying to come up with all the different kinds of things that might have been purchased during this time. It could be, don't forget linen. We've got listed a few other things there. Also, when you look at repurposing and modifying of space, Dwayne talked a little bit about the federal medical stations. The example there is the Javits Center in New York, which we've heard a lot about in California, the Veterans Memorial in the San Fernando Valley. So these are just examples, but within your organization, it may be old buildings that you're using that you've had to repurpose. It may be the parking lots. It may be parking garages. It may be unused hospital space. It could be recovery rooms that you're using in ICU, same-day surgery as an ICU. So try to think of everything that you've had to do differently than you normally do. Hard-to-discharge patients may be homeless patients, but it also may be someone that doesn't have anybody at home to be able to take care of them, so they're stuck in the hospital. Look at options such as recuperative care centers, look at home health agencies, also look at other agencies that are nonprofits, like a Home Instead that might be offering different kinds of services. So this is where your utilization management staff really have to be creative. They have to think outside the box and not assume that the way that these individuals were doing business before is exactly what they're doing today, because everybody is trying to do things differently to make sure that they can support the needs that are out there. In terms of length of stay, you want to be able to quantify the differences between what's happening now versus what was happening before, because we know that there's a demand for ICU beds because of the COVID diagnoses, but we want to make sure that we're looking at what kinds of patients are increasing your length of stay or the kind of patients that are using these beds, because we know we've heard a lot about from our clients that the patient volumes are down, but the kinds of patients that they have now are patients that are being investigated to see if they are COVID positive or other kinds of patients. So make sure that you're able to quantify and understand who's actually in your beds right now versus who's normally in your beds. Now, revenue cycle efficiency, this is where you want to have those folks that are non-clinical step up the monitoring of your admissions folks and the quality of the data that's going in, medical records, and making sure that they're billing accordingly in terms of coding, and also make sure that you have a plan for how your appeals are going to be done. We all know that during this time that there's a lot of bills that are not approved, so make sure that you have methodologies for that. Collection reconciliation, I'm going to let Tom talk more about that. Also, don't forget, when you look at delayed impacts, make sure that somebody is reviewing utility bills, electric bills, water bills, because some of these may change due to some of what's going on. I'm not going to go into a lot of detail for the rest of it, but I'm going to talk a bit about litigation. There is protection under the Act for volunteers, but not for anyone else at this point. Next slide. Now, in terms of reassignment of physicians and other providers and staff, a lot of this is already happening, and we're finding this out from our clients across the country. For example, anesthesia. These physicians may not be working right now either in the outpatient center or in your hospital, but they are being repurposed for being able to be used either in an outpatient setting or in an ICU or in the ED, wherever their area of comfort is. Same thing with residents and students. There's a lot of them that are being used in different areas. Make sure, though, that you get your labor attorney involved if you have union contracts, that you want to make sure that you understand what your liability is. Wherever possible, when you're reassigning somebody, please try to get a consent form for this reassignment so that you have some protection later down the road. Also, if you have, they may be assigned to off-campus sites such as clinics or drive-through providers that you have. And one thing you want to make sure you do is that you assure the competency. You may have to do some just-in-time training. Doesn't have to be elaborate, but have some documentation with signatures. Make sure, again, that you have these binders that you can develop so that you have everything readily available down the road. Next slide. You want to also make sure that where you have the option, make sure that you have a dedicated person. Make sure that the entire organization's involved, that you don't take a very narrow perspective when you're looking at collecting what the costs are and identifying revenue losses. Make sure that you have a dashboard of some sort. Now, you may, as I said earlier, have it as a manual dashboard, but somehow transfer it to a digital dashboard. You may need additional people to do that. Again, don't worry about the duplication. You can reconcile that later. This next item where you're trying to avoid allocating fixed costs, which is all of your management and salaried folks that you would normally have. You want to make sure that people that you have as additional that you brought in, those are the ones that you want to make sure that you capture. Quantify the prices depending on how much there is that's being cost as extra. Last of all, I want to make sure that you're prepared for your audit, that you gather data and have as much documentation as possible. I have one more lastly, Paul, I apologize. You want to make sure you support your staff and physicians. The workforce is starting to deteriorate. Make sure that there's a visibility of your leadership. Make sure one of the things you could do is try to bring in volunteer chaplains or volunteers wherever possible. Special thank yous, but be as creative as possible to make sure your workforce knows that you're supporting them and that you're there for them. Thank you, everyone. I'm going to turn it over to Tom to talk about cost and revenue capture.
Thank you very much, Margaret. So where cost documentation is really important, and of course that's important with revenue, but the key to identifying your lost revenue is going to be analysis. So you're going to have to take a base period. There's probably going to be information forthcoming on that from HHS to be able to provide guidance. But in different parts of the country, the crisis hit in some places starting in January, some places starting in February. So at this point, I would start to wireframe and try to think through, what am I going to use as the start of my crisis? It may not align with what ultimately comes out, but as we've repeatedly said throughout this presentation, there's going to be some windows of opportunity to make application. You want to be ready for those. You don't want to be able to have to start crunching the numbers and get me that report. And who knows what will be happening with your staff at that point in time. Hopefully they're all safe, hopefully they're all healthy, but there's too many unknowns about this crisis that we're going through, so you need to be prepared. You need to start working on it now. So our recommendation is pick a period for your baseline. And again, different parts of the country may have different views on this, so depending on what state you're in. For some, you may want to pick like the previous 3 months to be able to demonstrate, here's what I was bringing in as revenue. The effects of the crisis in the current period have dropped my volumes by 25, 50, 75%, whatever it is for that particular revenue stream. Some may want to say, you know what, our business is a little more seasonal. I want to look at last year's same period to compare it to this year's same period and do the analysis based on that. Or you may want to have both ready depending on what Congress and HHS may come out with. You should begin to develop your models now and get a handle on them. You don't want to be scurrying to get this done. You should be able to, you should start to set up your logic, what you should be looking at all your revenue streams. So there are some of the organizations on the line right now are ambulatory and outpatient. Some of them are hospital organizations or post-acute organizations. Whatever revenue streams you have, you need to be able to start taking a look at them. With this crisis, there's a lot of impacts, and they're not all volume driven. There's a shift in payer mix. COVID tends to hit the elderly more, so there's going to be a shift, a decrease in commercial, certainly because of the electives, but there's going to be increase in the Medicare, and there very well may be increases in the Medicaid. So while you may not eliminate commercial, we expect a payer mix, and for most organizations, Medicare and Medicaid pay less than commercial. The other thing that you can expect is a shift in acuity. For those organizations that have a high elective surgery volume, that's kind of gone away or been put on hold for now. So, and they're faced with more medical type claims that have typically lower margins and lower payment than they do for the surgical. So that's another issue that hits your revenue, but that may not show up as loss of patient days in total, but it's a deterioration of the revenue. You need to, one of our recommendations, and this becomes important, is to analyze on a paid claims basis. That's important because you're going to probably experience a period as things are getting shuffled around. And again, I think this is regionally specific, where there may be some issues at the health plan as they're losing their commercial payers, and people are going on unemployment. They may try to delay payments to yours or not make the adjustments in their computers. You have to be wary of that. So the law says that that for the costs and the lost revenue, that you're still expected to collect what you should be collecting from the payers. But at the same time, we believe that you should be taking a look at it not only on expected payment, but on actually what you're collected. You're probably going to have a great variability as to which health plans. For instance, you may have, a hospital may have rates for their Medicare inpatients that are tied to the Medicare DRG. Well, they should be reinstating that sequestration, and they should be adding that 20% COVID if you're basing your contracts. So you've got to look at your contracts and see what they say. If they've tied their revenue to Medicare and Medicare has just given an increase, then you need to hold their feet to the fire to make sure that that money is coming across. Because when it comes to audit, the agencies are going to read what the law says, and the law says that they have to get, that you have to receive payments, and they're going to provide you lost revenue for dollars that other people weren't responsible for. We're also seeing, like, one of the things that's in the act is interesting, and the reason you have to be prepared to not only track your costs and get a strong handle on that and your lost revenues is that 60 days after the date of enactment, the HHS secretary is supposed to start sending reports to Congress, and then every 60 days. So that means, according to when the act was passed, the CARES Act, that would be that they would have to present a presentation at the end of May. So let me then just go to the next slide, and I'll wrap up here. So in all of the things that you see here, I would view these as revenue streams. Some of the organizations on the line may be just physician practices, or maybe just outpatient surgery, they may be post-acute. What I'm about to say applies to you as well as larger organizations that may have multiples of these revenue streams. But you should take, because there are such variation between these revenue streams, you should analyze them separately. So you may have physician practice offices that are shut down completely, and that revenue is totally gone. You may have increases in your emergency room. You may have increases in behavioral health, depending on what's happening with your community. Increases in acute rehab or whatever. But you need to take those and analyze them, give it your best guess, put in your monthly management packets a new report that's showing the revenue loss, and summarize that and keep track of that. We also recommend that you begin to take, don't just crunch the numbers, take the information and create notes, narratives, minutes to be able to remember what happened now. How did you come up with those revenue loss? Who was involved in making decisions? What was your rationale? So that when you get into audit a couple years down the road, you have more than just chasing numbers and going back into your revenue cycle to try to figure out how you came up with what you did. And then before you submit anything, you need to validate it for your submission. Have a couple people look at them, make sure that there's not an error in logic. But when you're putting in your request, make sure that you would be able to defend that. So, Alan, I'm done here. I'm going to flip it back to you.
Thank you, Tom. Armand, can we go to the next slide, please? And the next slide. So it's always a tough act to follow, Dwayne, Margaret, or Tom. In a nutshell, there are some key considerations and then actions to take now. So this is more kind of your key considerations page. I mean, this is unknown territory. We've been talking a lot with our clients and others. You know, this is muscle memory that people have forgotten since the last time there was a big epidemic. You know, we tend to move to just in time when things are good, and we realize that that's not real functional during an emergency. So there will certainly be lessons learned from this, and that's really food for another meal discussion. Right now, I think what's really important is obviously collaboration and information sharing is going to be really important. And so it's very important to work with your advocacy groups. Your advocacy groups, of course, are collecting information and sharing with you. Very important for you all to push up to them. That's not a big news flash, but when we get busy, sometimes we forget that the advocacy groups are there for a reason. And now, not that they don't earn their money regularly, but now, of course, is a really critical time for them to be hearing from you all what exactly is happening on the ground and where you need them to push. Obviously, those folks are working with the regulatory agencies to formulate all this logic and processes. What I'll tell you right now is that as we're starting to work with folks, even the smaller folks that are dealing with the SBA loans right now, I think that's just the canary in the coal mine. So for those of you who are larger, we're already seeing the experience of how complicated this is all going to be with different rules and different opinions. Everybody has a plethora of opinions, very few facts, and there are already confusions between banks and the Small Business Association, for instance, on the first tranche of money coming out. And so it goes back to the bottom line is if you just think about blocking and tackling, what's really critical is to follow Margaret and Tom's advice. It is to make sure that you have concrete written documentation, not only of all your costs and revenue, but again, why did you make certain decisions and assumptions? Because you're going to have to pivot. Things are going to change. And so you're going to need to have really excellent documentation that you can pivot off of, including, of course, irrespective of what type of entity you are, really monitoring those healthcare payments, health plan payments closely. The health plans are experiencing, as Tom said, their own challenges right now. And so you're going to have to watch that really carefully and do that reconciliation to understand how you're being treated there. Let's flip to the last slide, please. So bottom line is the call to action. What's really key is that you are orienting and training your staff and your leaders on this. So you've got, as Margaret said, someone is responsible for driving your COVID response. Someone is responsible for driving this documentation. Everyone needs to understand what their job is. Not unlike your regular coding work you'd be doing, for instance, for HCCs. You want everyone to understand what you're trying to do, why you're trying to collect this information. Getting that cost capture, being able to financially model. Again, we're seeing it already, but this is not unusual, even in good times, even when there's not a disaster happening in real time, just dealing with Medicaid and Medicare through any kind of demonstration, they change their mind. The explanations and guidance aren't always clear. And so the ability to be able to have accurate data that you can model and to be able to model different scenarios, different benchmarks, and have that QA'd and solid and not be worried that you have a formula error somewhere. That's all really important. Again, it's blocking and tackling, but that's the kind of stuff that can really snag you sometimes if you're not thinking about it. Obviously, validation of your submission, irrespective of whether funds are just flowed early on. For instance, the 25,000 to 30,000 per bed that the AHA is asking for, or whether dollars have to be applied for. it doesn't really matter how the money comes. There will be reconciliation, there will be audit. And so that's really important so that down the road, you're not trying to continue to clean up mistakes that were made during what was already a stressful event. So that's really, in a nutshell, what we wanted to share with you all in consideration. What I'd like to do now is we've had a few questions come in. So I'm going to ask the panel to answer a few questions in the last 8 or so minutes we have on the webinar. So Dwayne, I'm going to start with you. We had a question just asking for a little bit of clarity around the $25,000 per hospital bed or $30,000 for those in higher hit areas versus the $47 per bed that you talked about in California coming from the Hospital Association. Would you mind, Dwayne, explaining the difference between those and why they're so vastly different?
Okay. The second bill that was passed by the Congress had $100 million to go into direct economic aid for providers. And CMS took it upon themselves to allocate half of that, $50 million, to the states to be administered through the state hospital associations for direct distribution to hospitals. So the $50 million was a decision by CMS. California's share is $4 million, and because it's based on per capita. And that meant that when you took the amount of money that was coming into California, divided by the beds, then it came down to the $47 a bed. And as soon as the money is given to the association, it will be immediately distributed to the hospitals. Now, the AHA requirement is, or request, is for money out of the emergency fund in the CARES Act, which was just passed late last week. And in that instance, what the AHA is recommending is that about $23 billion of the $100 billion be sent out in a phase 1 payment to hospitals to keep them afloat because of the cash crunch that they're in. And they took roughly a fourth of the money that was available, and that cranked out to $25,000 a bed for all hospitals, and then an additional $5,000 per bed in the hotspot areas. So those are coming from 2 different laws, and the processes are totally different.
Thank you so much, Dwayne. A question for Margaret. Margaret, is a question about nursing bonuses for picking up extra shifts and relief pay. Would that be considered eligible, in our opinion, for this $100 billion of funding?
You know, it should be. You want to capture everything that you can, because what you don't want to do is get short without that documentation later when you find out that it could possibly be approved. But more than likely, it will be, simply because of the fact that it is related to the fact that it is for your COVID patients. Now, what you want to make sure, though, is every hospital has something that they do during a crisis period, like our January and February months where we have a lot of flu patients. So you may have to go back and compare what you normally spend versus what you spent during this time to be able to show that you had extra dollars go out. But on the other hand, keep in mind that your volumes are lower in some hospitals or other organizations that are completely shut down or partially shut down, and the only thing you have are COVID patients. So capture everything, and then if I were you, I would also submit it, but when you're audited, you may have to be able to show the difference between what you normally spend and then what you're spending during this crisis. I hope that answers your question.
Margaret, thank you so very much. We have 4 minutes left. I'm probably going to be able to get to one more question, so I just do want to repeat that we are going to be sending everyone after the webinar a PDF of the PowerPoint, a link to the taped webinar, And we will take all the questions that were submitted, provide written answers, and have a written Q&A. So if I don't get to your question, please know that we will get to it and get it out to folks on the written Q&A as soon as we can. So Tom, you get a little harder question. The question is, would they allow a base comparison of revenue, or do we have to measure it by cancellation of elective procedures based on CPT, DRG, et cetera?
Thank you. Yeah, so again, we'll have to see how, if they add guidance on this, but in our opinion, the law says that if you've suffered a loss of revenue because of the effects of COVID-19. So our interpretation is that it's the crisis, it's the COVID-19 crisis that's causing the loss of revenue. So from our perspective, probably the most logical way to do it, it's not just about those specific procedures that were canceled or kicked down the road. It's about, here's my baseline revenue and here's my revenue now. My organization is suffering. Now, if the revenues are the same, the other side of the ledger that may be captured, it might fall on the increased cost for certain organizations, where they may not see a lowering of total revenue. But the important part is, and it's not just COVID patients. A patient comes into the ED, they think they have COVID, they don't, they're not a COVID patient, but it was still the crisis that created that situation. So we would say take a broader view. There's some defensible positions written into the law. They don't say that all of the monies that they are spending have to be spent on COVID patients. It's being spent on the crisis. I hope that helps.
Thank you, Tom. Very helpful. I know we're running out of time, so there have been a number of questions. I'll just do a quick summary of a number of questions related to the small business opportunity, how an individual practice could combat this crisis, what about the small business forgivable loans, and so we'll include information on that as well. Right now, again, as I've said to you, that's a good example of how complicated this is going to be. There are a lot of conflicting messages out there in terms of how to apply it. Every bank is treating it differently. And so we will provide you with updated information on that. But what generally I would say is, if you are a small practice, if you're a small multi-specialty, and you fit within the SBA guidelines, then we absolutely would recommend that you pursue that funding as well, and not limit yourself to the healthcare funding. So a simple answer for folks asking those types of questions is, don't forget that you're also a small business, and limit yourself to the healthcare dollars. With that said, we can't thank you all enough for joining us. We know you have a lot on your plates right now. We wish you all and your families the very best of health. And if you all have questions for us again, or would like to set up time to talk, please reach out anytime. Meanwhile, take care. We're going to end the session, please.